Hello everyone, welcome back to Medical Coding Club. This is Chandrika. So today we are going to learn about emergency department evaluation and management service. So I have taken a patient record. In this medical record, we will understand how the ED physician can do the service and also how to assign an appropriate ENM code for ED physician and how to dissect the procedure. Everything we will learn today using the patient medical record as well the code book. Okay, so we'll implement the coding guidelines and then we'll assign an appropriate codes. So please do watch video till end, and if you find it informative, please do subscribe to my channel and please do share with your other medical coding friends as well. So yes, let's begin. And also, if you any one of you interested in getting CPC training classes, you can WhatsApp me for this number, and I will update you with my new batch details. So yes, now as I said, we are going to discuss about emergency department visit. Before diving into medical record, I would like to first discuss few coding guidelines, and I will show you the codes first. Then we can assign an appropriate code for the medical record. So yes, so you can see emergency department services. So we'll understand more about ED now. So here the first coding point is you don't have to look whether this patient is a new patient or established patient. Okay, for ED visits, there is no distinctions between new or established patient. Okay, this is one coding point. And then in an emergency department, if provider provides or render the service for a critically ill patient and that critical care service is more than 30 minutes, then you can assign code from the set, okay, 992912 99292, based on if it is more than 30 minutes of critical care service provided in the emergency department, then you don't have to assign ED codes. Instead, you can assign critical care codes. And same way, to understand more about what is emergency department, it is just the a particular portion of the hospital where it considered as emergency room, and this facility must be available 24 hours a day. Okay, it will always be open, and it's not like only a critically ill patient will go to emergency department. It depends on, it can be a simple problem or it can be much complicated problem. Okay, but once the patient go to emergency department, how the physician is providing the service is the physician is making the patient to get admit, or asking the patient to get admit, or giving the critical care service. So based on the service given in the emergency department, we will code based on those services. Okay, so understand here, an emergency department is designed or defined as an organized hospital based facility for the provision of unscheduled episodic service to the patient who present for a immediate medical attention. So here, like, the appointment is not required. So if you have some emergency or if you just have some kind of problem, you can go to emergency department. Okay, so which is inside the particular hospital. So next, and in the ED, like, if patient is taking service in the emergency department, it is still considered as outpatient service. Okay, until or unless the patient get admits to the same hospital, the patient will be referred as an outpatient. Okay, so once the patient get admits, after filling that admission form and after paying the certain amount for admission, then this patient will be considered as IP patient, inpatient, and you can refer the code from this particular code set. Okay, whatever hospital IP and observation service codes we have, from that particular code category you can take the ENM. Okay, so as long as patient is not getting admitted to hospital but just taking the service in the emergency department, he will be considered as outpatient service, he's getting outpatient service, and you should code from the section below to emergency department. Okay, and then coming to time as a factor in emergency department setting. So you can see time is not a descriptive component of the emergency department. So most of the ENM services, we have two category. Either you follow MDM based coding guideline or time based coding guideline. Okay, and if both are documented in the medical record, what you will do, whichever gives you the higher reimbursement, that particular coding guideline you have to follow. Okay, but coming to emergency department, you have to follow a solo coding guideline, that is medical decision making. Okay, you will not have time coding guideline here, because ED physician will have many patients, so he will be, he can't give the particular individual attention to the particular patient. He has to go here and there. So time is not a descriptive component of the emergency department. You have to follow medical decision making coding guideline, and accordingly, according to MDM, you need to take the codes. Okay, so now let's see the code set. So here you can see emergency department codes based on MDM alone. So 99281 you will assign when the service was rendered by nurse practitioner. Okay, any mid-level provider is giving the service, then you can give 99281. And 99282, this is for straightforward medical decision making. 99283, low MDM. 99284, moderate MDM. 99285, high MDM. Okay, so these are the 5 codes we have for emergency department. Okay, for this category. And with this 5 code, we do have one more code. Okay, so most of you may not be using that code, but you should be aware. So we have other emergency service code. Okay, so that is 99288. So this code we will use only when the physician or other qualified healthcare professional is giving a direction for emergency medical system. So whenever patient requires advanced life support, so you can read more about other emergency service here later. So for other emergencies, we will code 99288. Okay, so for normal ED, whatever the 5 codes we have, from here 99281 to 99285, based on MDM and based on who is providing the service, we are going to assign the ENM codes. Okay, this is about coding guidelines of emergency department. And in my classes, I will teach everything like what is ED and what are the other coding guidelines, and in which situation we will code IP services, observation codes, everything. So here it is difficult to cover everything. So now, yeah, after the codes, now we will get into the medical record, and then we will assign the particular codes. Okay, so just a minute. Okay, so yeah, so I was just opening the emergency department coding fee ticket. Okay, so that it will help you to understand how we accurately assign the codes. So yes, coming back to the report, so you can see it's an ED department visit, emergency department visit. Patient name John, date of service they have given, and this ED is in Westcare Hospital. Insurance company is Okay, Etna. So I think I have changed here to Cigna because I have opened the fees ticket Cigna. So let me make it to Cigna. Okay. So insurance company is Cigna, and so patient age is 54 year. Okay. I think my screen is visible. Yeah, it is visible, I think. Okay. John is 54-year-old male patient, and today's chief complaint is chest pain. So what and all you need to check in medical record? So first thing, check about the patient age criteria and place of service, and then chief complaint. Why the patient is here today, that you have to check. So patient is having chest pain, and here they have given details about the chief complaint. Okay, so how the patient is suffering related to that particular problem, everything they have discussed. So next, past medical history. This is also important. You need to check patient to like in past he had a hypertension. Coming to past surgical history, hernia repair. So next, medication. So there are too many medications. So you have to check medication usage whenever you are coding for the chronic conditions. Okay. So now I'm not going to discuss about these medications. So next, social history. So there are all of these things, you just you can take time and you can just take a glance. Okay, so what is necessary in the record, that we will discuss. Coming to physical exam, so physical exam should be documented. So based on that, we can identify any particular system has any abnormalities. So here they have given the vitals of the patient, and they did all organ system examination as well. Okay, so I think everything looking normal here. Normal. So everything looks normal. Next, coming to ED course. So here, what the physician is doing, like in order to treat that chest pain, what are the diagnostic or what are the procedure that provider is performing, that you need to check. So ECG ordered. Okay, so the physician ordered ECG. Next comes to assessment. So here assessment, patient is a 54-year-old male with a pericardial chest pain and thoracic aortic aneurysm. So all of these problem, whatever they have given, have been ruled out. Okay, have been ruled out based on the above history and exam. So the meaning, you have to consider patient is having pericardial chest pain, single problem, but whatever the rest problem he has given here, all of this problem are already ruled out. Okay, like not detected. Okay, by seeing these problem, do not think like he has all this problem. So somewhere here they have mentioned have been ruled out. Okay, so ruled out means you cannot consider those as a final diagnosis. Next, differential diagnosis still include. What is differential diagnosis? So please remember, whenever they document differential diagnosis, you can't code them. Okay, but you need to understand there is a risk. Okay, there is a risk, there is a possibility. Okay, it could happen. So the chances of pericardial chest pain, the uncertainty of the chest pain, they are documenting under differential diagnosis. Okay, so you can see acute myocardial infarction, coronary artery disease, myocarditis, unstable angina. All of these are clinically high risk. Okay, so these are the physician is highlighting that this patient problem, the pericardial chest pain, could lead, okay, uncertainty they have documented here. So this knowledge you should know for your chart A, MDM chart A, problem addressed. whatever the chart we have, for there you will be able to identify what exactly your problem level. Okay, so later once we go to MDM calculation, I will come back here again. So this is about the problem, and then the patient requires further workup. I have discussed the case with Dr. Levitt, hospitalist, and agree with the admission and work plan for the further testing. So we agree proceeding with the echo before admission and requesting for cardiology to consult. Okay, so this is a discussion that one provider is doing with another provider. Okay, you should know that we have a particular coding point or a data management point where one provider is consulting or one provider is discussing with the external physician. Okay, that is one more point here. So next, he has also ordered labs, CBC ordered, CMP ordered, lipid panel, and one more test ordered, and results are updated from the lab. Okay, so you can see the result here. All the lab results they have attached. So it is here. And lastly, you need to check for the signature of the doctor. So the signature is completed. Okay, so fine. Now we have these much, or these many labs and the result, what to say, data risk. Okay, so you can see the final plan here. Admit to admit to inpatient floor, and the patient is not yet admitted. It is the discussion or the decision made by the ED physician. Since I am coding for ED physician, here I will be reporting ED codes. Okay, if I had little more about IP service, I would have changed my code to IP. Okay, so then imaging reviewed by me. So please refer the formal report. So X-ray imaging was interpreted by ED physician here. Okay, so we need to report for his interpretation and report only, not for the entire service. So first, now we will go back. We will understand what will be the MDM level comes to this particular, medical record. Okay, so as I said, do not get confused here. The plan is asking the patient to get admit. Okay, as of now, and we don't have particular further details about the IP, whether the patient got admitted or not. So let's keep it for emergency department alone. So coming back to our medical decision making, so how we gonna do it? So everyone is aware already. So everyone is aware already to calculate the MDM level. So you can see we need to, for MDM, we have three components. The component one, chart A, number of complexity of problem addressed. So you need to find your level from this particular chart. Next, you need to check your amount and complexity of data reviewed, which is chart B. You need to identify how many data points you got. Lastly, the risk of complication. So chart C, here also you need to find out what is your level. Okay, so taking all together, you need to pick the two meeting level. Okay, any two charts which are meeting, and you can ignore the least one. Okay, just one highlighting one coding guideline. So if you get all three charts in a different level and no particular charts are meeting, then you will follow the MDM hierarchy and you will take the average level. Okay, so I have already discussed more about all of these things. Please go back and check how to assign or how the details about the medical decision making chart. You will understand. So yes, coming back to our problem was pericardial pain, right? So as I shown in the medical record, patient had pericardial chest pain. So now, for this pericardial chest pain, they have added the possibilities or the differential diagnosis include, and they have added all the clinical problems. Okay, so which are all kind of myocardial infraction. It's all acute conditions, acute myocardial condition, which can give you the higher level. Okay, so but for our problem addressed, where is your particular problem? So that you have to identify now. So whatever the pericardial problem I told you, it has a uncertainty. So you have to consider it's a one undiagnosed new problem with the uncertain prognosis. Since they've added all those clinically high problem, okay, in the differential diagnosis list, you need to take it as a one undiagnosed new problem with the uncertain prognosis. So the your problem addressed level would be moderate. Okay, this is chart A is moderate level. Next, coming to chart B, here we have already had 3 plus labs. Okay, so alone lab only giving you 4 points, and with that you also had a discussion management or a test interpretation. Okay, so that is one more point. So you are meeting two categories now. So whenever you meet two different categories, your data level will be high. Okay, so your data chart B is high. And lastly, coming to chart C, which is risk, here they made a decision regarding hospitalization. ED physician asked the patient to get admit to the hospital. Okay, so the admission part is considered as decision regarding hospitalization. Okay, that hospitalization comes here in the high. Okay, so risk chart C is also high. So chart C and chart B are meeting as high level. So you are taking these two as meeting points, and your MDM will be high MDM. Okay, so what will be your code? So let's check that. So you can see this calculator also. So let me take emergency department. So you don't have to, as I said, you are established patient, you don't have to worry. So next we will look into, as I said already, one undiagnosed new problem. So I already kept here. So next you can see ordering of each unique test, 4 tests, and discussion of management test, that also have selected. So together, lastly, we have decision regarding hospitalization. Okay, so for this, what is the level you are getting? High. Okay, so totally your MDM is high complexity, and your ENM code is 99285. Okay, 99285 is the ENM code for this particular emergency department medical record. Okay, so easy. So you got to know what is the ENM. So let me enter that code first. Okay, so place of service, what will be the place of service? It would be 23. So for your reference, go back to page number 3. So check for emergency room. So emergency room, hospital, okay, 23. So you need to enter your place of service as 23. Next, the first CPT code, what we got? We got 99285. Okay, first CPT 99285, and quantity is 1. So some dummy fees is there here. So you can just keep it for your reference. So after calculating the MDM and after leading your ED ENM code, now we will go back and we'll look for the procedure. Okay, so you have seen that physician have ordered labs here. Okay, also ECG ordered. Okay, so remember, whenever you are coding for ED physician, if lab is not interpreted by him, we can't code for labs. Okay, in this medical record, he did not interpret the results. Okay, it was purely outside the hospital. I mean, it is from the laboratory, and it's not it belongs to ED physician here. So we are not going to bill for any lab service. Okay. So next, looking into ECG, he has said that my personal interpretation. Okay, that meaning is that particular ECG image he has interpreted. Okay, so for that interpretation, he should get paid. Okay, since he is an ED physician and getting a physician charges. Okay, so you need to only pay whatever the service he did. Okay, so from hospital side, we have taken the technical component. That means the X-ray machine is from the hospital. The ED physician here, ED physician service or work is just giving interpretation of the X-ray. So he should get paid for only the interpretation and not for the entire, ECG service. Okay, so I think I said X-ray, so not X-ray. The ECG, okay, the technical component of that ECG, particular ECG machine, you could, mention it. So now coming back here, let me show you the codes, how the codes are categorized, CPT codes. So you can see 93000. So electrocardiogram, routine ECG with 12 leads with interpretation and report. So this particular code is a global service code, okay, where physician owning an equipment as well interpreting the ECG report. That time, usually in office visit, you can bill 93000. Okay, because physician will have the own clinic equipment and they are only providing the interpretation. So we will bill a global service code 93000. But when it comes to hospital ED, for that ED, and that you are billing for ED physician, you would only bill whatever he did. Okay, so in our medical record, the physician did interpretation and report only. Okay, so I need to assign 93010. And for hospital, I could report 93005. Okay, so we can't bill both now because I am billing for ED physician. So I am going to report 93010 for whatever the ECG work he has done. Okay, for the particular patient. So my second procedure would be 93010. Okay, and if you think about any modifier usage here, here you can't use any TC or 26 modifier. Okay, TC or 26 modifier you can't use because what to say here. See, coming back to book. So 93005, tracing only. Tracing only is nothing but it is all about the equipment. So the technical TC modifier. Okay, you can't report TC modifier with 93005 because the CPT code description will tell you it is all about technical component. Same way, 93010. With this code, you can't build 26 modifier because the CPT description, it will tell you this is for professional interpretation and report only. Okay, so you should not use any TC or 26 modifier for these CPT codes. Okay, and then coming back to the diagnosis here. So we got a final assessment, under assessment, 54-year-old male with a pericardial chest pain. Okay, so pericardial chest pain only you have to code. So let me check the diagnosis code as well. R07 something will come, I think. Okay. Pericardial pain. So R07.2. Okay, R07.2 pericardial pain you can report for this particular medical record service. Okay, so you can just keep R07.2 Here also you have to link R07.2. Why? Because for this pericardial pain, they have performed ECG. So medical necessity should be there. I mean, should match, so that you have to link same diagnosis with the two CPT codes. First one is ENM code, second one is ECG interpretation codes. Okay, so that's all. So this is about ED coding. Okay, so I think I have not, like I don't have enough time to keep it everything in PPT. So I have discussed live. I have shown you how to get the codes and everything, the MDM, the decision, everything is here. Okay, so if you have not understood any particular point regarding MDM, please go back and check my old videos regarding MDM. I have explained all the MDM tables. Okay, and also that's all. So once again, I will come from above for your. This is a real-time medical record. Okay, I have just, as I said, just have made changes in insurance. It should not be like a real medical record. Okay, so I've just changed the name and some changes I made. That's it. So this is how we will code the ED reports. So to learn more, please do subscribe to my channel, and please do share with your medical coding friends. And as I said, my new batch will be starting from December 15th. So if you are interested to learn CPC syllabus, you can join my classes. It's online and it is affordable fees. So that's all. Thank you all. Thank you for watching this video.